I'm sorry, I see some people haven't got any there. So we're in video.
Keith, the film will be on YouTube. You go to YouTube and put "These Cuts Won't Heal." That's
Okay.
the channel.
Okay.
There are various films from going back a few years about various things.
Okay. So two relevant and helpful interventions, so we'll carry on now. So I can answer to Catherine Mears, who will start us off with some ideas of food law.
Thank you. Apologies to those who were here about a month ago when I spoke. I'm giving a similar talk, but with a few updates that I've thought about since and whatnot. I haven't got a PowerPoint, but if Keith asks me again, I'm going to have to get one. This will take about 10 minutes, 10 to 12 minutes. Just to say again that my name's Catherine Mears. I live in Amber Valley. I've used Ilkeston. I'm from Long Eaton originally. I've got professional and academic qualifications in community health, and I'm carer to an elderly parent who has received excellent inpatient care in Ilkeston in the past. I'll summarise the points I made in the previous meeting, and then because we have representatives here tonight from the Clinical Commissioning Group and the Derbyshire Community Health Services, thank you for coming, the provider and the Commissioner of Services, I thought it might be helpful if I conclude with a few questions for them as well. I've got 4, but I'm sure people in the audience will answer those questions. But as I was thinking about this, 4 sort of coalesced. Of course, as a retired health worker and currently a campaigner, I don't have access to all the data available to the CCG and their partners. So I can't, obviously that's a limitation. I do know, however, that this push to say that care will be provided in the community rather than in a community hospital is a push from the National Health Service, NHS England. The campaign to reduce beds nationally has affected us here in Derbyshire. It's a knock-on effect. However, even that was called into question very recently by none other than the boss of NHS England, Mr. Simon Stevens. I quote a press report from June 2 months ago. It says, shutting beds has left hospitals unable to cope with the growing number of patients needing care and needs to stop, the head of the NHS has admitted. In a surprise U-turn, Simon Stevens, Chief Exec of NHS England, said the policy had gone too far and that hospital beds had become overly pressurised as a result of years of closures. The number of beds in NHS hospitals and other facilities has fallen between Q2 of 2010 and Q1 of 2018 by 14,500. That's about 10% of the total. So he says he wants hospitals to increase their supply of acute and general medical beds. He doesn't mention community rehabilitation beds, but I would have thought they would be in the mix. So what's the real context behind all of this? I'm going to quote you again from the CCG meeting, the notes of it, January 2019. Quote, the level of savings required in Derbyshire means that the CCG will no longer be able to afford to commission all of its current services at the same level, as it needs to be ensured there's sufficient funding to maintain essential healthcare services for the local population. Savings programmes will be built upon this basis. I didn't receive a clear answer in the past when I've asked what constitutes essential healthcare services. My concern, of course, is that a service where health and allied professionals lead rehabilitation in a community hospital setting of frail elderly following, say, stroke or hip replacement, for example, would not fall into that category. Maybe we could have some clarifications later on that. Now to the local issue which brings us here tonight. Let me just read out the survey questions which the CCG have put on the website as part of their engagement process. There are 5. What do you think about our plan to increase community support beds? Oh, that's good, that sounds nice. What do you think to the plan to use Lady Cross House Care Home to provide the additional community support beds? Oh, that's okay. About reducing the number of beds at Ilkeston, do you have any thoughts on this change? Well, obviously I'm going to have some thoughts in a minute. What do you think about our plan to increase capacity to support more patients at home? And is there anything you don't understand about the plans outlined in changing the provision of community rehab in Erewash? So hopefully, you know, this will help you to, if you haven't filled in the survey, tonight will help you to fill it in with a bit more information. I think my presentation, in effect, is a verbal response to those questions. Firstly, the strapline for the Derbyshire CCG plans for Derbyshire generally, for the whole county, is called joined up care, care closer to home. They're transforming care. This is always portrayed as progressive. Not all transformation is progressive, but it is portrayed as that. However, and I quoted this a month ago, but I find it very compelling, the Nuffield Trust, which is an independent, not a campaigning organisation, in a research paper called Shifting the Balance in March 2017 says, they look at these models of transforming care and balancing everything out. It's called Shifting the Balance. They say, a significant shift in care will require additional supporting facilities in the community, appropriate workforce and strong analytical capacity. These are frequently lacking and rely heavily on additional investment which is not available. The Trust continues, many initiatives we examine place additional responsibilities upon primary and community care at a time when they're struggling with rising vacancies in both medical and nursing staff and an increasing number of GP practices are closing. Addressing these issues is a necessary precursor to success. So that's already of concern. And that's not us saying that, that's the Nuffield Trust. So now the specifics about the transformational plan, and I really look forward to your presentation. You might be able to clarify some of that. But from my perspective, from our perspective, first of all, you want to reduce the number of available pathway-free beds. These are nurse beds in community hospitals where patients have daily access to nursing care, but also to occupational therapy, physiotherapy and other allied professional inputs as required, so that they can have a safe return home, whether that home is a care home or their own home. Cuts in community hospital beds already in the north of the county have resulted in a total of only 32 beds now in 3 locations. Whereas in April 2018, a Freedom of Information request I put to DCHS totalled 93 beds for the north of the county in total. Note also in that Freedom of Information request that I asked for, that they sent, they gave me the average bed occupancy rate for Ilkeston 2017 to 2018 was over 90%, which indicates to me a continuing high demand. Yeah. The CCG defends community bed cuts in the north of the county by saying that outcomes for patients have improved. But although I've submitted a written question to the CCG asking for the written evidence for this, I've not yet received an answer. Yeah. The CCG always claim that time in a hospital bed, especially for frail elderly, leads to deterioration in their condition. But any evidence quoted is of course about extended stays in acute hospitals, usually due to delayed discharge. And discharge is delayed because there's not enough provision for safe discharge in the community, and that includes community hospital rehab beds. To me, that's catch-22. So now to the Pathway 1 beds at home. These are going to make up for cuts in the community hospital beds. These are in your own home, Pathway 1. But this is at a time when district nurse numbers nationally have halved since 2010. And continue to decline due to falling district nurse training places. District nurses are crucial in supporting rehabilitation in the home. Also, the CCG has decommissioned recently many voluntary sector organisations and activities, including Community Concern Erewash, which supported up to 1,000 frail elderly to stay in their homes. Yeah. So that doesn't quite fit. And we all know the parlous state of social care in this country, including in Derbyshire, our own county. Just a few weeks ago, peers of the realm, including former Conservative and Labour Chancellors, called for an immediate £8 billion of investment to tackle the, and I quote, national scandal that has left over 1 million vulnerable older people without proper social care support. The committee said 1.4 million older people were denied the care they needed as a result of cuts, means tests and rationing, while others received extremely basic clean and feed levels of care. Many as a result were housebound and unable to fulfil everyday tasks like washing or going to the toilet. And we know, as a consequence of this, it's inevitable that people can and will languish at home, in bed or on the settee, or in something like that, due to insufficient care inputs, just like they can in an acute hospital. But the difference is, at home, they are conveniently hidden from view and statistics.
Yes.
Anecdotally, I've heard of frail elderly being discharged from acute care in Derbyshire directly to home. This is a home first scheme that they've introduced because they already have carers in place 4 times a day. They deteriorate quickly and have to be readmitted. This is both cruel and it's not cost effective. Having adequate rehabilitation beds would reduce this shuffling in and out of hospital and all the distress which this causes. So now, to talk about the pathway to beds in a care home with additional support as required. The care home quoted in the CCG survey they asked us to complete for patients of Ilkeston and surrounding area is the Lady Cross House Care Home in Sandyacre, run by Derbyshire County Council. This is a residential, not a nursing home, with a maximum of 35 beds. A CQC inspection report published in April of this year deemed that the care home requires improvement overall, with 3 of the 5 criteria requiring improvement. Let me just read a short excerpt from the report of the CQC. Care plans were not always up to date or detailed to ensure the information required for people's care was available. When people expressed themselves with anxiety which could cause themselves or other harm, there was no care plan in place to support their needs. When people required care at the end of their lives, there was no care plan to reflect on any last wishes, arrangements or pain management. That's your pathway to solution. Clearly that, I'm not blaming the facility because we all know what strains they're under because of no social care funding from central government. But clearly that facility is already struggling to meet the needs of the current clientele. How can we have confidence that it will adequately meet the needs of those who otherwise could have been rehabilitated in Ilkeston Community Hospital? Finally, to quote the Nuffield Trust again, while out-of-hospital care may be better for patients, it's not likely to be cheaper for the NHS in the short to medium term, and certainly not within the tight timescales under which the STPs, that's the Sustainability and Transformation Plans, are expected to deliver change. The wider problem remains. More patient-centred, efficient and appropriate models of care require more investment than is likely to be possible given the current funding envelope. So we assert that at a time of ongoing demographic change, we're always told we're all getting older and we're all using the services more, there's an increased demand. It shouldn't be about either community hospital beds or care at home or in a care home. It should be about both and. And the major concern in Derbyshire is that we're going to end up with neither. So my 4 questions that I would just like, to, and I'll submit these later if it would help. But my 4 questions, and you can ask questions, but my 4 arising from this. 1, where's the written evidence that community bed cuts in the north of the county have resulted in better outcomes? How is this being measured and monitored and recorded for us? Number 2, where's the written evidence that stays in community hospital beds like those in Ilkeston are detrimental? The only papers I've seen are referring specifically to acute bed stays. Number 3, we've always been promised that no bed cuts will go ahead before the community capacity to match that service are in situ. So where are the itemised, scheduled and budgeted plans for guaranteed improved care and adequate numbers of appropriately qualified staff able to provide that in both the care homes and in patients' own homes? And number 4, could you let us know what's your timetable for closing the beds? Have you already gone down to 16? And if so, what's the point of the so-called engagement? Thank you.
great to ask Kath some questions after that interesting presentation, but we're going to hold on. I shall speak briefly, and then our friends from DCHS and UCD will speak 25 minutes, and then we'll do all the questions. So I'd rather it didn't interrupt me. No one interrupted Kath, and they didn't interrupt our two speakers from the two organisations. Is that okay? There'll be plenty of time for questions. I just need to throw in a couple of bits of information here. When we arranged the meeting, we invited Maggie Throop to come along, and she pointed out that she was away tonight, and I said, can you send somebody else instead from your team to explain your views on this matter? And she said she wasn't able to do so. I think I've circulated, you can perhaps see the letter which Maggie Throop sent me to my home in Cantelupe. Okay.
Sorry to interrupt.
Don't interrupt, Paul.
Isn't that?
Throw that man out.
Isn't that the second time she's not come to a meeting that she's been invited to?
So, this is what I have to say. Please do share copies of this, because there's one between two, again, and you keep one for yourself. Okay, thank you. Due to expecting nobody to come, and somehow I was wrong. So, this meeting has been called by Derby and Derbyshire Keep Our NHS Public. This group, under various names, has been going for about 5 years, campaigning against underfunding, privatisation and bad decisions across the whole county of Derbyshire. It's called the Health Footprint, the whole area. There are also local groups in Belper, Derby, Chesterfield, Matlock and Amber Valley. It's a national network of groups. Do I say the bells? Okay. Derbyshire Footprint Clinical Commissioning Group is a statutory body responsible for planning and commissioning of care services in this whole area. They hold most of the money, not all, which pays for services. Derbyshire Community Health Services is a provider of hospitals and other health provision. From 1948, when I was born, to 2010, the national average government spending year on year for the NHS increased by 4%. It was needed year on year. Since 2010, it's only been 1% per year, causing major underfunding across the country and a crisis. A big chunk of that budget goes on administering the markets and privatisation, not on health or staff. The recent announcements of an extra £1.8 billion from the government in the last few days to be spent on capital projects, such as buildings, is a con. This is neither all new money, there is some, nor enough to repair our NHS. 20% of this money hospitals already had, but were blocked from spending, said Labour Shadow Health Minister John Ashworth. Professor Alderson added, we welcome additional investment in hospitals, but this announcement is like an absentee landlord saying he'll mend the shower. But the broken toilet, damp walls and dodgy electrics will have to wait. And none of this capital spending is coming to Derbyshire or Ilkeston. Derbyshire Health Footprint, this whole area, including Ilkeston, despite complicated funding arrangements, which you get some back and lose some, get some back and so on, is being forced to cut around £69 million this year. Can I be that? Oh, thank you. Sorry. So, this is the newspaper of the national organisation which I belong to and has local groups work. It's called Health Campaigns Together. And so I've given a bit of a picture, I think, about the national picture, decided by government being willing for the last 9 years to cut back again and again and again, when actually more money was needed. And when you spend money on health, it's money well spent. Not just in terms of healthier workforce and healthier people, but also in terms of employing health staff. And I'll conclude on this point, which is the recent plan, it's called the 10-year plan for health provision, has a very poor understanding of the need to recruit more health professionals. There's not really a good plan anywhere near the top of their list of priorities, and I think that's a major concern. So, thank you for listening to that, and we'll answer all the questions you want to ask in about 25 minutes. I'm very pleased to be able to, I have to introduce yourselves because there are so many of you. I can't work out the names. I know some people. I really appreciate that you've come, and I know that two of the doctors are going to make a presentation in a moment. Please, if you wouldn't mind all saying who you were, that'd be really helpful. Would you mind just say who you are?
Hi, I'm Zara Jones. I'm the Director of Commissioning for the CCG.
Thank you.
I'm Kate Brown, I'm Director of Joint Commissioning and Community Development. Hi, I'm Jo Warburton, I work in Joint Commissioning at CCG.
Actually, what's joint commissioning?
It's commissioning jointly with social care and advice.
With social care and advice. Okay, thank you.
Hello, I'm Dr. Steve Lloyd. I'm Executive Medical Director of NHS Derby and Derbyshire Clinical Commissioning Group.
Hello, Ben Pearson, I'm Medical Director for DCHS and Community Services.
Good evening, I'm Will Jones and I'm Chief Operating Officer for the Derbyshire Community Health Services NHS Foundation Trust.
Hi, I'm Rob Steele, I'm Head of Communications for DCHS.
Hi everybody, Andy Kemp, Head of Comms for CCG.
Thank you. So, 25 minutes. What do you know? I'll stop you.
I don't think it'll take 25
Okay.
minutes to go through
It's,
the presentation.
no questions during this presentation, but questions afterwards. Okay? Please do carry on.
Thank you very much, colleagues. Thank you very much, citizens of Ilkeston and Erewash for coming tonight, because we really welcome this opportunity to share our thinking, but an opportunity to listen. And that's the most important thing in my mind, as a doctor, as a GP, that we listen. We listen to people's views, but equally we share what we think is the right thing to do for the people, not just of Ilkeston, Erewash, but also of Derbyshire, given the constraints that we face. And we do face constraints. Let's not beat about the bush regarding this matter. But what we try to do is the right thing. We want quality of care for our patients. We want the right care in the right place at the right time. And as a GP, that's always foremost on my mind. As the Executive Medical Director, whatever we do, it's got to have that critical focus and that critical leadership. So we've come here tonight to talk about the change, potentially the provision of community rehabilitation in Erewash. And I thank the previous speaker and yourself, Chair, and some of the comments I've heard already, for the questions. We'll try and answer some of those questions, but if we can't answer them directly, we're not trying to be evasive. We take them away and we respond. But also, we consider this in terms of what we propose going forward. Just like to make that clear, okay? So listening is everything. I recognise some guys who come to the governing body. You sat behind me, weren't you? Yes. So, yes, so if I may, so like I say, setting the scene. I know this is a strongly emotive subject for everybody. As patients, as carers, and as family. I've been a patient, I've got family who are elderly in care settings, and it's really important to me personally, this whole issue of care in the community, but care in the most appropriate setting for need. That's the thing we need to hold on to. That's the thing we need to hold on to. And getting that right level of support in those situations. So our priority, like I say, is to provide the best level of care and treatment for our patients and our communities. Okay? It's really important, I think, when we talk through all this pathway redesign, because that's what we're here to talk about, pathway redesign. We're not here to talk about closures. We're not here to talk about closures. This isn't about closures. This is redesign of clinical pathways, following the best national advice and local experience thrown into the mix as well. So I hope that's clear to people. This isn't about confrontation. This isn't about, here's the plan, we're going to do it. It's about hearing what people think and how we can use that opinion to shape plans. So like I say, what are we doing? What are we doing? It's about change in the care of patients in the rehabilitation pathway. And the key to understanding this has already been outlined, hasn't it? It's what P1, P2, P3 beds. I really hate talking acronyms. I used to work in an environment outside of medicine where acronyms were just, you just get lost in the jargon, basically. But as has been outlined, P1 is on the presentation, in the patient's home, with a care package, okay? And that's social care and health care, wrap around the patient. I would say it's a bit of a euphemism, wrap around care. And I can understand scepticism when people will say that. I get that, okay? But this is how we redeploy resource. Pathway 2 is that intermediate level of care. And we've talked, heard already, you know already about the residential settings. It's a community support bed with support from health and social care, in addition to the staffing at that particular unit. And pathway 3 is where patients require that 24-hour health cover in Ilkeston Hospital. In Ilkeston Hospital. We've described this already in the conversation straight away, haven't we? What is pathway to community support beds? The fundament of all this is to get people back home where they belong. Okay? Nobody wants to be in hospital, young or old. Nobody wants to be inappropriately in the wrong setting in a hospital. It's about getting at care levels that's most appropriate in the right setting to enable people to get back home to their own environment with their families. And this is what pathway 1, 2 and 3 concept is all about, what it looks like. So pathway 2, none of this is anything new in terms of concepts, but there's a distinct paucity of pathway 2 beds in Erewash, in Ilkeston, and we need to beef up that whole pathway up, because the average stay in the pathway 2 bed is only 2 weeks. We've got no cost to patients. So what does it look like? You all know this. You know, I'm trying to teach people to suck eggs. Where are we at the moment? We've got the P3 beds. We've got a paucity of supported beds in the community in pathway 2, and definitely in pathway 1. It's all front loaded to P3. So yes, people go there and get an excellent service, but are they there appropriately? Do they need to be in pathway 3 beds? That's the nub of it. This is where we all need to think hard about. Yes, pathway 3 beds, the hospital, Ilkeston, good, fine, excellent service. But what about those patients that really don't need to be there, and just as importantly, don't want to be there? Where do we deliver that most appropriate level of safe and quality care? That's the difficulty at the moment. Is doing the best for our patients in Ilkeston. What we want to move to is a much more flexible response to need, not just the demand, but to individual need. When we consider patients, everyone's an individual, everyone's got individual needs. And it's tailoring that level of support to those patients through pathways 1, 2 and 3. So we need a much more balanced approach to this locally. And this is not just something we conjured up and thought was a good idea. You know, this is this is what the national view is. And the people may disagree with that, and yes, fine, but we need to talk through how we deploy that resource, not just in the hospital setting, but into the community as well. Because that's the most powerful thing that we can do for our people, for our patients. Because the world has changed for all of us from 10 GP, Lewis, from 10, 20, 30 years ago. The world has completely changed, not just demographically, but socially. And we need to keep up with that change and to deploy resource effectively and efficiently to those things. Okay, if you want to carry on.
Okay, I'll say a few words.
No, we'll just keep going and keep going.
Thanks, Steve.
But happy, we'll take questions afterwards. Anything we can't answer, we will take away. Okay? It's not a big secret thing. This is about. No, it's not. Okay. Ben, sorry.
Hello everyone, Ben Pearson. So I've recently started as the Medical Director for DCHS. Prior to that, I worked at the Derby Hospitals. So I'm a consultant in geriatric medicine and the healthcare of older people. And I worked at Derby as a consultant for 15 years. During the last 5 years, I've also worked out in the community. So I've worked with GPs in Pena and in Belper, and I've worked in care homes, looking after people largely with dementia in care homes. And over the years, I've had hundreds and hundreds of conversations with people and their families about what next after the acute hospital phase. And they're not easy conversations to have. And one of the most important things for me is that people have a choice and that we can meet their needs safely. And I'll describe an example about these different pathways and why it really matters to me that we've got pathway 2. When people are getting ready to leave an acute hospital bed, they should undergo a good multidisciplinary team assessment, and we should take into account their wishes, but also what's practical. And one of the most important practical things I can think of is the care that you need overnight, particularly for people with dementia. And the reason I say that is that it's a risky time overnight if you're struggling to get up to go to the loo and there isn't anyone to help you. I'd love to send everyone home because that's where they want to go. Some people want to be in their own home. But I haven't got the resources, and social care haven't got the resources to provide 24-hour care, particularly overnight. That's not really a choice in my mind. It means we're committing people to not going home, staying in the acute, or going to pathway 3, which isn't always the best environment. One of the pathway 2 bed things that I've worked in is the Florence Shipley Centre up at Hena. It's a very nice building. It's got wide corridors. It's got excellent facilities like comfy lounges, kitchens for people to practice in, rehabilitation, occupational therapy, social worker attached. But if you need to get up in the middle of the night to go to the loo, there's always someone to help you. It hasn't got a hard floor like this that you might slip on and have an accident. Pathway 3 beds in hospitals do. Particularly with dementia, the calmness of the environment and the skills and the competences of the staff looking after you really matter. People want to be at home because it's familiar, because they can manage better in their familiar environment. But in a hospital environment, even Ilkeston Hospital, even Pathway 3, it's busy, there's equipment around, a whole load of new strange nurses that you haven't met before. And I think for people with dementia, that's one of the most tricky things to cope with. And if it were my mum, I'd far rather she was in a care home environment if that were what was needed. So I agree with Catherine's point. It's not either or, it's both and. But we've got to get the balance right. And I think this is what we're trying to do. I've said that. I've said that. We've said that. And we've said that. It's really important, that link we've got with Derbyshire County Council and Social Services. That's extremely important. I've read the CQC report about Ladycross Care Home. I would understand your concerns. We would want to work with Derbyshire County Council to improve that picture. It's all about making sure people are safe. An important point about changing provision is reinvesting the money where it's needed. So making sure that we can support people at home and we can provide these pathway 2 beds. And that includes the staff. Another important thing, really important for me from the point of view of clinical governance, is making sure it's working and continually reviewing the quality of the service that people receive. And there's all sorts of things that we could track and monitor. That's really our statutory duty to do that. Another important point at the end there about flexibility, to make sure that really specifically in Ilkeston Hospital, if we need more beds at winter, we can provide more beds at winter. Thank you very much for listening to me.
Are we on time, Chair?
Hey?
Are we on time?
You're within time.
Within time. Because that's the most important thing. It's not just being on time, but making time to talk. Okay?
And I appreciate Steve and Ben for your contribution, very valuable, presented in a very measured way, so thank you for that. I think we now need to ask a number of questions. The question is quite a short sentence with a question mark at the end. So this is not the time for making long speeches. Is that okay? The questions are very important. And I'm going to try and make sure that everybody gets a chance. So please do put your hand up and I'll try and make sure everyone is recognised. And I'm especially interested in people who live in Ilkeston. So I'll shout out your name. We'll start at the back.
Hi there, my name is Terry Riley. I wonder if you can specifically explain to us the methodology used in the north to measure whether this was a good outcome or not.
Thank you. We'll do 3 questions and an answer.
We've got a whole team here.
Yeah. Chuck, maybe?
Yes, Frank Phillips. Yes, my question is written down. I'm pleased to see we have a police presence, by the way. I just pity they can't protect you from the CCG.
Sorry, I thought I did the joke.
No, I wrote it. The Joined Up Care Derbyshire plan promotes a model of care which rests on the premise that there will be additional support available for patients deemed well enough to be supported at home. This includes not only health and allied professionals but other community support systems, with reference specifically to the plans to reduce community beds at Ilkeston Hospital from 38 to 16. Why did the CCG decommission last year the community concern Erewash, which had been supporting around about 1,000 clients who were vulnerable residents, particularly the frail, elderly, terminally and long-term ill and disabled, 9 one of them.
And later, I'd like to know if you can tell us what the difference in cost is from a bed in an acute care hospital such as Derby Royal Derby, or Ilkeston Hospital, or the home. What is the difference in those 3 as cost-wise?
So will you decide to answer which of those questions?
Yeah. So, Zara got most experience.
Do you want me to kick off then?
Yes, absolutely. We'll all sit at the front here.
Yeah.
Am I over here? Do you want me to come over here?
Yeah.
Yes. So, scroll down those. I hope you got these right. So if I start with the voluntary section, community concern, in terms of that question, and I'm sure a lot of people in the room have known from sort of previous conversations we've had in public and at our governing body in public, where we've sort of gone through the whole process with the voluntary sector and some of the difficult but important decisions that we've made, particularly over the last few months. In terms of that particular scheme, and with all of the schemes actually that we've reviewed, we've always consistently said that we really recognise the value and contribution that those individual schemes have made, and I suppose I just want to make that point again. But we've had to make a very sort of important step in terms of looking at all the different schemes that we've supported over the years through grants and contracts and other means, and decided whether, through a very rigorous process which was clinically led, and we've reported through our governing bodies, so very happy to reshare the information about that process and how we've done that, is to make some very important decisions about whether we felt we could continue to prioritise spend across some of those schemes. For the community concern scheme in particular, it's unfortunate that actually it's ceased to be before we finished our entire review, and just to recognise that point really in terms of that time, but it would still have gone through the review process, and it was continuing to be in place when we reviewed all the other schemes. So I suppose my answer is that we've made some very difficult decisions, but we stand by those decisions because we do have a finite resource, and I think some of the speakers already this evening, some figures have been quoted about levels of savings that we have to make and sort of the budget we need to work within. We have to, for the taxpayer and for the local community, decisions, but the right decisions. And that's our role to do that. But we have, for the voluntary sector in its entirety, we have gone through a very rigorous, clinically led process. And I personally presented those findings to the governing body last year, so very happy to reshare that information.
So just to be clear, the argument from Steve and Ben was that the decision to reduce the number of beds at Ilkeston Community Hospital was based entirely on medical, clinical information. You're saying you're keeping within the budget which has been imposed on you by the government. You're saying something different.
No, I don't think I am. So I think what I'm saying is that we do have to make sure that we spend the Derbyshire pound. Well, we can only spend it once for a start, and we have to make some very difficult but the right decisions in terms of how we prioritise that spend. In terms of the beds, because I was answering the question around the voluntary sector and community concern, in terms of the beds, the key driver around the beds and maintaining 16 beds of P3 at Ilkeston Community Hospital in the future is very much driven around what Ben and Steve have presented this evening in terms of having the right capacity in the right places. And what we have seen through evidence and through looking at auditing patients and where they go when they come out of, for example, the Royal Derby, is we see more patients who have been identified with clinical need to go into P2 beds actually going into P3 because we haven't had the P2 capacity. So a fundamental part of this plan is actually having enough of the P2 capacity. Therefore, some of the occupancy levels, which I think Catherine had cited before, that we've seen over 90% and above, although it is lower than that now, is down to, in some cases, because patients in those beds who actually have been clinically assessed as needing the community support beds, the P2. So by redressing the balance, we can have the right patients in P3, P2 and obviously P1 at home. And I think that's just a really important point to make. The driver is not making cuts for financial reasons, but however, we do have to manage within the budget that we've got, and we do have to make savings. And we've said, and we continue to say that publicly at every governing body meeting of the city.
Just to say that 5 years ago there were 44 beds in the office.
Yeah.
I can say things, but I'm not going to. That's not what I'm here for. More questions from people, especially.
I was just going to say, there's just mixed messages here. You're either saying, the first speaker was saying it's going to be reinvestment, and you're talking about savings. There's just it's just mixed messages.
Well, let's do 3 questions and then we'll come back. Well, let me just yourself answer the questions, or will you be answering questions as well?
We'll all answer questions.
Okay.
Could you answer the question I asked first?
Yes. Okay, well, So the question you asked, you think it wasn't answered?
So it wasn't answered.
So who will answer that question? Repeat the question.
What I want to know is the means that were used in the north, where I understand something similar has happened, to actually evaluate that the outcomes for individual users of the service were good and valid.
Yes, that's good. Keep moving, folks. So, please do come and.
Yeah. One of the main things is about, as we said, it's important to assess needs. So in terms of assessing where somebody's needs, what those needs are, ensuring that they then end up in the right place. So we have seen in the north that people are ending up in the right place that's been assessed for their needs. And then we're also tracking whether they get readmitted to hospital and whether those readmission rates are low, and those are the measures that we use to check that their outcomes.
I don't want to start a dialogue, but very briefly.
Can I just say, that hasn't really got anything to do with human outcomes, has it? We assess that you go in a certain place, and lo and behold, you go and assess that that was the right place. Where is the discussion with the individual users of that service to say, I'm much happier the way I've come this way, and these are the reasons why?
I'll take that as a point made, because I want other people to join us. Gentlemen there.
Excuse me, I didn't get the answer to the question I placed before about the cost of the difference in the hospital beds. I'm basing this, can I just explain? I'm basing this on my brother, who's now taking a bed up in Royal Derby, and he's been assessed as needing pathway 2, and there isn't anywhere available. And so surely he would have been better in Ilkeston Hospital rather than Royal Derby, but there isn't a bed there either. So what I'm saying is surely it's better cost-wise. I would have thought, maybe I'm wrong, I'd like you to tell me, does it cost more to be in Royal Derby?
Yes. We'll come back to that one after one more question, because we keep things going.
Yeah, I haven't got the answer.
I know, but we'll come down to that in a minute. One more question.
I'm just going to ask the same question about the rating. Has anybody got any specifics on how much each one costs? Not just double talk, actual...
I think, as I said at the outset, and I hear a lot of questions, we come straight out. We hear a lot of questions. If we can't answer them fully to satisfaction, we are taking them away, and we will answer them. So in terms of
So what I'll say, just in terms of cost, so yes, it does cost more to stay in an acute hospital setting. Obviously, the actual cost for a patient will depend on how long they're there, what interventions they have, etc. So the cost is more expensive, I think, is the easy answer. And yes, the cost then in a P3 community hospital would be less, and I think C2 would be less still, depending on, I suppose, the support to those patients. So it's not that we're trying to evade the answer, it depends for an individual patient how long their length of stay, etc. would cost. But yes, it does cost more in an acute hospital.
Frank Dunham with Ilkeston, could you explain to me, am I right that when this was brought up and started in the north of the county, it was following a period of consultation where I believe that down here in our area, you bypassed consultation and gone straight into engagement? And can you tell me the reason why you bypassed formal consultation?
One more question. One more question. A big question.
Yeah, John Frook. The lady at the front just made the point that yes, there is a cost to keeping people in acute hospitals. Those acute hospitals it's a breaking point anyway. So what other effects to that hospital just keeping people in acute beds could otherwise be facilitated in a bed in Ilkeston Hospital or other hospitals?
So do you want me to start the consultation?
I have to say, though, that the questions are quite short. And the answers need to be quite short.
Fine, okay. So the question around the consultation versus engagement. So in the north, there was a consultation as it was deemed to be significant service change. There have there have been some hospital closures and a sort of reconfiguration programme. In terms of the changes for Erewash and for Ilkeston, there will still be P3 beds available for patients who need them. So we are doing this as an operational change in terms of the numbers, but importantly, that we're going to have additional reinvested capacity, if you like, within P2 community support beds and P1 at home. So that's the difference between the two.
So does that clarify that and confirm that there is no consultation, you've bypassed consultation, you've gone straight into engagement, and you've based that decision purely on, you say, the opinions in the North matter because it's a significant change. Well, we consider this a significant change, so we feel that consultation should have taken place.
Yes.
And we are disappointed that it hasn't.
Some of the points being raised here so far, to summarise so far, is we need to look more closely at the 44 beds coming down to 16 and 18 in winter. We need to look at a question. Hold on, please do come in. Go on, you'll find that. So one issue that's so far is in the air is that 5 years ago there were 44 beds and now it's considered reduced. Secondly, there's the whole question of to what extent are the decisions being made based on clinical decisions about it being better to do things this way, or actually is it about cuts in money? And thirdly, the question that's being raised just now is to what extent has been a proper consultation or engagement process? Okay, I'm looking for this.
Pam Phillips. How many staff worked at Ilkeston Community Hospital and what were their job titles in A, April 2018, B, currently, C, once beds have been reduced to 16.
How many staff are we losing?
How many staff are we losing?
And I'm going to recognise that it was Ilkeston person that actually told me they were going
The presentations, both of them, appear to justify the reduction of hospital beds on the ground of flexibility. Can you tell me how reducing the hospital beds from 44 to 16 could create a more flexible situation with regards to
Yeah, thank you. So the question about the numbers of staff, I haven't got those figures in my head, but I can explain to you what's actually happening. So since the CCG decided to undertake this engagement, as Sarah has explained to you in the answer to the earlier question, we have an obligation as the employer of the staff, we're the organisation who run the ward, we're the employer. We also have a legal responsibility to undertake consultation with our employees. So we are actually well on with that process. We can provide you with the answer to those questions in terms of your A, B, C and D, but the staff that are affected here, we're talking, as far as the ward's concerned, we're talking about qualified nurses, we're talking about healthcare assistants, we've got physiotherapists, we've got occupational therapists, and we've got support staff who work to make sure that the patients are hydrated and fed properly. Now, what our objective in all of this is to be able to redeploy everybody that will be affected by the change. So in terms of the proposal, if the CCG decide when they get to their governing body meeting, I think it's in September, we would then need to enact that in line with that decision. And our consultation that's taking place at the moment with those colleagues is about making sure that we are able to retain as many, ideally everybody, and to redeploy them into alternative roles. So for example, there will always be physiotherapists, occupational therapists, healthcare assistants and nurses on the ward if the reduction, as the gentleman has confirmed, takes place. But what we will also need, as Dr. Lloyd and Dr. Pearson explained, is we will also need to have physiotherapists, occupational therapists and therapy assistants that will be working at Lady Cross at Sandy Acre. So that's an example of how we will redeploy them. We will also need to have more nurses and more therapists working in the community to be able to support people who will be in the Pathway 1 beds and receiving that rehabilitation and care in their own homes. So the message overall is it's about redeploying colleagues, and in it, and we now know that we will actually need to take on some extra staff. We will need to employ some extra physios and extra OTs to be able to make this process.
I let the bell finish first.
Bell practice tonight, I'm sorry.
As I said at the outset, the world has changed in a very short period of time. And I get what people say about 40 odd beds 5 years ago, and where are we now in terms of halfway through. The whole concept, like William's outlined, of having integrated care teams outreaching into the community to maintain people in both Pathway 1 and Pathway 2 beds is new, and it's been built on and evolved as time goes on. And that's what I talked about in terms of flexible response and capacity that is not just within the narrow lens of where's the P3 beds, but included in that quantum, Pathway 1, Pathway 2, Pathway 3, with appropriate levels of care. Because in my mind, this is where we just need all of us to carefully understand what is actually the bed capacity we're talking about. Because we're not comparing like with like. 5 years ago or 10 years ago, we have got integrated care in the community, and that is the aim, and that's what we need to develop more strongly, because only if we have that can we prevent people going into hospital in the first place. And as a GP,
Cooking was a GP.
Thank you.
Shipping.
Yeah. As a GP, I can tell you we have much more comprehensive cover with our partners in the community health services, in the mental health services, than what we've ever had before. And not just in my bit of Derbyshire, but in Erewash and Ilkeston as well. And this is a journey, this is an evolution. It's a journey we're on to giving that much more comprehensive cover across the pathway, from acute hospitals to community setting to general practice in locality, their own practices.
Okay, Tom, Paul.
Okay,
Time to shout and through.
So I'm a nurse in the NHS myself. My question is, what do the staff think? And the reason I'm asking this is because a similar thing tried to happen on our ward in our community hospital in Notts, and the staff weren't very happy about it. And I have physios, OTs, psychologists, and social services integrators anywhere. We weren't happy about it, so we demonstrated against it, and after 7 months, the decision was overturned. So I want to say to the people of Ilkeston, if you fight, you can win.
I think the question does hang over these meetings about whether or not it was a good decision to do what was proposed.
Paul, should the replacements be put in place before the cuts take place?
Can we answer the first question?
Yeah, I'll go with that one. So, as far as our colleagues, the staff that we employ at Ilkeston Hospital, the employees of the trust, we pride ourselves with engaging very, very closely with all our colleagues. Now, this has been a long process. We've been talking about this with colleagues at the hospital for about 12 months. I've done my very best, supported by local trade union representatives, to make sure that we've engaged and kept the staff posted at all stages. can I just ask, are there any colleagues from the trust on the ward here this evening? So, but we have got trade union representatives here. They may wish to make some comments. I think the honest answer is that none of us like change. It is always difficult to be able to accommodate change. But the really important thing is if we work hard at informing people, keeping them well communicated, care for their wellness and the issues that crop up as they go, and we work hard with them to make sure that they get redeployed, as I answered the other question, into roles that they feel happy and comfortable with, to support them and provide them with the additional training that may be required. That's the best that we need to be able to do, and try our very best to help people with that transition.
Can I just say, as somebody who answers questions as well, I'd rather we talked about cuts, because that's more truthful in terms of, it's not just about change, it's about cuts. And secondly, one of the problems which exists with staffing is when staff feel that their hospital is about to be reduced or their pressure is about to increase, they get a job somewhere else. Okay, I'm not trying to wind people up here, but we all know that one of the hospitals in the north of the county, 200 people went to a meeting, we were reassured that hospital would not be closed, at least not straight away. It was closed straight away, and the reason was because the staff left and it stopped being viable. So there are different factors. When you talk, William, about the wellness of the staff, that is very important and staff feel insecure. So that was my response to that. I'm trying to work out, especially people from, okay. Paul's question, sorry, Paul's question.
So that was about the alternatives in place, wasn't it? Yes, absolutely. So in terms of looking at how many sort of beds and capacity at home that we need across P1, 2 and 3, we've modelled those numbers and we've looked at the data in that respect and the evidence of what we need. And absolutely, so we have not enacted the changes that we've talked about yet. We're doing a period of engagement. So the maintaining 16 beds at Ilkeston Community Hospital is on the premise of having 11 community support beds, Lady Cross and Florence Shipley, and also having what we call 37 slots available in terms of support at home for patients. So those things are all need to be in place, and we said that in our governing body meeting when we talked about these proposals that we're going to engage on.
But, sorry, there've been 44 beds in 2010, was it? We're down to 16 now. Beds have been cut.
It was 36 last January.
Sorry?
It was 36 last January.
Yeah,
36. It was 32 this time last year. And so it's not right that it's going from 24 down to 16. Within the last 18 months, it's gone from 36 down to 16, which is more than half. So I'm jumping out of turn, but have there already been put additional beds through the other schemes, considering it has gone from 36 down to what I understand actually is now 22 because they've now closed one of the wards.
So in terms of the work that we've done to see that we've got what capacity do we need in the different pathways, those numbers which I've just quoted are the numbers that we need. Therefore, in terms of 16 beds, we wouldn't be doing 16 beds without those things in place. And that's the commitment that we've made. We made last year that we wouldn't until we've got alternative capacity in place to do that. So that position hasn't changed at all.
Okay. Say your name and...
Me first?
Yeah.
Oh, right, Mike. I'm from Belper, but I've got a point to make which reflects on both Babington Hospital in Belper and Ilkeston. When we were told last March that Babington Hospital was going to close with a loss of 20 nurse beds, rehab beds, we were told not to worry because there would be provision available in Ashbourne and Ilkeston hospitals. Now we're being... Well, exactly. Now, we're faced with the fact now that there are going to be 16 rehab beds, respite, end-of-life beds, whatever, nursed beds across the whole of southern Derbyshire. I'd like to ask the CCG how they think that is actually going to maintain vital services to patients.
Dennis Birkin. Can we have assurance that when these people are sent home from hospital, they will get the proper attendance? People are going to see it, look after them, because I know if it's going over to private firms only give them so many, perhaps a quarter of an hour to prepare a dinner, to get the dinner ready for the dinners for them, or even less.
Are you
I know
saying
my
in some
daughter did
cases
it.
things are moving across to private firms?
Yes. Is it going to be a private
Ian Thompson, just a simple question. Have you discussed the closure of Ilkeston Hospital on the CCG?
The only person who's ever mentioned that is
Direct. No, we're not considering closing.
You're not being informed.
Okay, so in terms of is 16 beds enough? So I suppose I don't want to annoy people by repeating the point, but it is the consistent point that we've done the modelling about the number of beds that we need, and what we consistently see is more patients are in the community hospital beds who have been medically assessed as needing community support beds, the P2 beds. So therefore, yes, in terms of that modelling, and we've built in the flexibility, which I think someone referenced earlier, in order to meet that requirement.
It's getting lots of hands up now, so I'm going to try and... So just stop the bus. Take it in a moment, very brief, please. Lady here and gentleman there. Are you going to stop the bus? Take it briefly and then lady here and gentleman there.
I was going to talk about my own experience. I was in hospital for 8 days with a sciatica where I could not actually stand, basically, and I was in hospital. I was 4 days bedbound, and what occupational therapists actually in Chesterfield Hospital do effectively is to go around to one particular ward, give the person physiotherapy to try and to get the person up to their feet. It's a lot easier, a lot more efficient for occupational therapists to go from one bed to another bed to another bed in the hospital rather than tazzing around the community. It's inefficient, it won't work.
It's more of a statement really. Margaret Steptoe, I was a patient in Ilkeston Hospital when they had 44 beds. And I was in there after being got up to bed for accident. And when the bed became empty, within 2 or 3 hours, it was someone else was transferred there. Yeah. So I fail to understand why you only need 16 beds when all those beds were needed. And we're always hearing about the acute hospitals having a shortage of beds and beds transferring people to Ilkeston Community Hospital obviously alleviates the acute hospital.
There is a sense, Sarah, that the actual modelling you've done about how the beds are needed is under question.
And I suppose the answer is that when we've looked at the evidence and done audits of patients in those beds, is that what we found is there are patients in the community hospital beds at Ilkeston who would have gone into P2 beds, community support beds, if that provision was available. So that's why we've seen them over-occupied.
Okay, I'll come to everybody. Did I miss you out at the very back? Yes. The gentleman there is not Actually, I couldn't hear that. Would you mind?
I would like to know why a large number of beds have been cut before provisions have been made in the community for the alternatives, and also to point out that care in the community, if it's done properly, it's expensive. You know, it's not.
Okay, gentleman there, and then we'll do some answering before we start doing some opening. Gentleman there.
Yeah. Is this a ploy by Simon Stevens, the head bloke in the NHS, to try and privatise the old lot?
It has been argued that the 10-year plan will create units across the whole country of an appropriate size to privatise, but that's just speculation. There was somebody here and then somebody here. Actually, I'll come to you in a second. You haven't had one go. But you haven't, so please do.
Well, my name's Peter Gibb. I live in Ilkeston. I'm concerned that A, you're cutting the beds down. You haven't included the provision yet, and could you give us a budgetary figure for the upgrade of that place at Sandy Acre and a time scale as to when it will be implemented, because I've not heard that from anybody on this point this evening. And I think it's reprehensible what we're doing at the moment. I accept that we have to have change and we are in a changing lifestyle community. But I would like to see and understand what the budget is that can allocate it, how are you going to work with Derbyshire County Council who are already closing other homes, and how and when are you going to implement those changes?
Okay. And one more question and have some answers.
We've spent a lot of time this evening talking about hospital beds and moving patients from bed to bed. The big gap in all the provision is in social care. The people who actually go and support people in care homes and in their own home. And we've already heard that that service is in absolutely decimated. That's all very well, making plans at the moment. But what we've forgotten, which was mentioned at the beginning, is that we're only just beginning the start of even bigger cuts coming online in the future. If we're trying to plan a good service with excellent support, with those cuts coming on stream, how are you going to develop effectively and support and increase the services that are so needed?
Yeah, I just wanted to bring to mind that a few years ago the Hena Hospital actually closed, and Ilkeston was supposed to provide the service that that hospital closed. And another point is if there are shortages now in with the care home or Ilkeston Hospital, if there's shortages now, what's going to happen come winter?
Keith, I'll try. There's a lot of questions there. I might not have captured them all. So, Mike, Mike asked about the question about the promises that were made regarding the proposed changes at Babington and Belper. Just to be clear, we have a network of Pathway 3 beds across the south of Derbyshire. I'm going to have to look at my piece of paper to remind myself. So, Mike mentioned Ashbourne, he mentioned Ilkeston, he didn't mention Ripley, and neither did he mention London Road Community Hospital. And there are Pathway 3 beds at all of those locations. And as Steve and Ben said, all of those facilities will be available for people, and the idea is that we would always look, depending on the assessment that Ben and Stephen talked about, to try to get people to the bed that's closest to their community. It's not always possible, but there's a network of beds across the south of Derbyshire. On the budget that somebody asked about, what's the budget for the services that have been provided at Lady Cross? Again, I certainly don't have that at the tip of my fingers. I'm sure that Zara doesn't have it either, but we'll have to get back to you on that one. But the really important thing I want to emphasise is that the arrangement that we're talking about at Lady Cross at Sandyacre is an extremely well-established model in Derbyshire. Roger and my colleague here, who's here from Derbyshire County, we've been working on this model for about 20 years on and off, under different guises, different names, different administrations, whether it's Simon Stevens or anybody else, but the principle is exactly the same as Steve and Ben have outlined. And it's a very, very well-established model. We have excellent working relationships between the CCG, who pay for the social care at Lady Cross and pay for the health care that will be going in, and it's up to us between Derbyshire County Council, Adult Care and DCHS to make it work, and it works extremely well across the whole of the rest of the county, so we're trying to develop and build that up. On the timescale, again, Zara and I will be very closely on this. The timescale will depend on once the decision is taken by the CCG's governing body, and it will then be up to us to work together to come up with a plan. We will need to engage with all of the different partners involved, engage with the staff, make sure that we've got everything in place and do it in a safe and appropriate way. As far as social care is concerned, and what's the model that we're looking to develop into the future, comments have been made already about the 10-year plan that was published in February. And one of the really, really important aspects of that plan is that we are now general practice, primary care as it's called, community health services, acute services and adult social care required to work together under the guidance of the STP, Joint Care Derbyshire and the CCG, to integrate community health and primary care services at a place level. And your place here, covering Ilkeston, is the patch of Erewash. And the commitment is that all of those organisations that I've mentioned and others working together to be able to do the best with the budgets that we've got to meet the needs of the people of Erewash and the 7 other places that there are across Derbyshire.
I want to begin to draw things to an end soon, but not immediately. So do make sure your question gets asked. Then
Are you better we've got 10 minutes before comes off again?
Oh, bless. It's a good till 9, so you've got 10 minutes.
all right, okay. All right. Okay.
7 to
The
the
key
morning.
phrase, I think,
Oh, yeah.
Go on.
is the phrase within the budgets that we've got. And I think, that's maybe a different starting point for you. We recognise that we're in a situation where since 2010, there's been a range of health and social care right across. Its funding base has been destroyed. And do you agree, or do you believe that the government has given you enough money to do your jobs effectively?
The population going up, not going down.
Well, I raised the issue of living within the budget that we've got. We're all public servants. We have a responsibility to work within those budgets, those delegated budgets that come down through the system. I'll be absolutely honest with you, I've worked 35 years this year in the NHS. I'm very proud of that long service. And I would say to you, to be absolutely honest, to answer your question, there's always the opportunity for more money, for more investment. But I also know that I've got a responsibility to work within the budget that's made available to me.
Can I just follow quick clarification then? How many nursed beds have you got now? Or is it 16?
At Ilkeston.
At Ilkeston.
At the moment,
yes.
There are 22 beds that are open at Ilkeston, and there are 2 additional beds that make up the 24 that we've always had, we've had available for the last 12 months.
What
so
are the extra 2? Are they flexible ones?
Yeah, so we had, up until last Thursday, we had 2 12-bedded wards.
Right.
We've had difficulty in being able to staff those 2 wards, so we consolidated all of the beds that were available prior to that.
And then like just one little question for clarification.
A question from Kath.
The CCG is meeting, the governing body is meeting in September. What is the decision they will be making there in terms of Ilkeston hospital beds and the timetable?
So it's to review the outcomes of the engagement that we're currently undertaking. And on the basis of the outcomes of that engagement, for the governing body to decide whether they agree with the proposals that went to governing body a couple of months ago to have 16 P3 beds at Ilkeston and an increased number of P2, which is 11 in total, and 37 what we call slots of P1.
With the timescale
of implementing, as William said, so it's, I can't remember the date, it's the first Thursday in the month of September when we have a governing body meeting. If it's agreed at that governing body meeting, we would then be quickly looking to put that in place from then.
So how are you going to increase the P2 capacity within days?
So we're already working really, sorry,
Is it worth clarifying? The beds at Erewash are already designated.
Just to clarify, you are from the council.
Yeah, we're from adult care.
You adult care.
And the beds have already been designated and are available at Erewash and are operating as a halfway sort of arrangement at the moment. So we're already receiving people directly from Royal Derby Hospital who've been identified with needing P2 capacity. And we're doing that with the resources we've got, because until the CCG actually made the decision and the CHS enacted, some of the resources that will be required are not available. So we have as I said, we are moving in that direction. People are already benefiting from those beds being available. And while I've got the floor, just to respond, I do understand people's anxieties that they've read any CQC report that says that any service requires improvement. But what we didn't add was that CQC requires an action plan to be put in place whenever they do an inspection, which identifies that improvement is needed. And the Lady Cross action plan is already in delivery. And we're confident that when CQC return, which is likely to be in September or October, that the issues that they identified, which were not about safety of care, will have been addressed.
So you have 11 designated beds ready to roll now?
We don't have 11 though, because 3 of the Erewash beds are in flowship
Let me just say, I'm going to recognise one more speaker, but I want to begin to move things to end. Not do it straight away, but what happened was that I invited Maggie through to come and speak, and also Catherine Atkinson to speak. So I'd like them to say something, well then, Maggie's not actually not Maggie, to say something before our friends go, and then it'll be time for them to go. And after they've gone, just briefly, I want to just run a little session about what we think we should do next. So that's the plan. Chrissy, final question.
What is the scale of the budget cuts for next year? In figures.
So this is the final answer now from this side of it. So who's going to answer that?
So at this stage, we don't know the answer back because we haven't received our allocations for next year. And it's not normally until the autumn time when we start what we call the planning process and we start to see what those numbers are. My expectations are that there'll be a similar savings challenge as to what we've currently got this year.
And how much is that?
Our current savings plan is 69.5 million.
This is cool. Okay, so I would have invited Maggie Troop to speak, but Catherine, that's your turn.
Thank you. I'd say I very recently had my personal bout, and had this meeting been a week earlier, it would have been saved from hearing from me. But I am particularly thankful for Ilkeston because it was the MIU and the out of hours, which meant that when I burped an infection, I received the care that I needed, and I feel much better and get to be here with all of you tonight. Today, many of you will have seen in the news that it's been confirmed that we have across the country record waiting lists. Record waiting lists. And previously, when people were leaving acute care locally, they could feel really confident that there would be a bed for them at Ilkeston Community Hospital. And now, they don't have that confidence at all. The particular frustration is, yes, of course, some people would rather go straight home, but for so many, they have no or limited care at home, and they certainly, even in a care home, won't have 24-hour nursing available and medical facilities that they may need. Now, the thing that does get me a bit cross is to be told that somehow these bed cuts are going to lead to a better service. I think what all of us would really like is just some honesty that this is cost cutting. And I mean, I don't believe, and many people that I've spoken to, including staff and patients, don't believe that the beds would be being cut if it wasn't for unprecedented NHS cuts in Derbyshire. And we were told that we were talking about 24 beds being cut down to 16, which does ignore the fact that this time last year there were 32, and actually at the start of the year there were 36, and obviously we've heard previously 44. So it's not that things have changed massively over the last 5 years. In the last 18 months we have already seen cuts. And I do think that a particularly damaging falsehood was when we were told at the public meeting last year, and subsequently by the MP for Erewash, that talking about bed cuts was scaremongering. We were told that it wouldn't happen, and because we believed that, because we trusted that commitment, we stopped campaigning. And we stopped the campaign, and I think that's what, for so many people, they just will never trust what they are told about the hospital again. But I just want to be very clear, we've heard that the MP can't make this evening and couldn't make the last one, and I don't think that's good enough. But I want her to join the campaign. I think it's important that we have an MP in Westminster talking about the fact that the local hospital is being cut. I think it's important that she lobby government to be saying we need more money for the NHS, not less. I think a legacy that you'll be the only MP in history, certainly that I've ever heard of, that doesn't stand up for your local hospital is not a legacy we want to see in Erewash. But the reason that she gave for not joining the campaign was because she said that I said that the hospital is closing. Now, many of you have been campaigning with me over the last 6 years when it comes to Ilkeston Community Hospital and the minor injuries unit, and my social media and my leaflets are all in the public, but I want to be absolutely clear, I have never, ever said that the hospital will close. Ever. What we were talking about was bed cuts and maybe the closure of one of the wards. And that is exactly what we have already seen. And having cleared that falsehood up, I very much hope that the MP will now come and join the campaign. I genuinely don't believe that they're actually going to completely close Ilkeston Community Hospital. I don't think it will be closed. But if you cut the staff, and you cut the beds, and you cut the equipment, and you cut the services, then it becomes hollowed out. And what we did see last Thursday, when many of us were outside Tolvar House protesting, was that the ward was closed very, very quietly. There was no press release about it, it wasn't on the website, there was no social media, there was no press coverage of the fact that the hospital ward had closed. I found out via staff and patients, and it shouldn't be for me as a candidate to be letting the community know that their ward had closed. And I think that's what people just don't quite believe when it comes to openness and transparency, because we are really grateful that you've come to this meeting. I think it's very important. But when we're not told when the cuts to beds have been happening, as they have been over the last 18 months, when we're not told when the MRI scanner is decommissioned, even though it was provided through funding from local people and legal friends, when we're not told when the ward is closed, when we're not told about the huge effect that having the loss of charities like Community Concern Erewash has made, which saved the NHS tens, if not hundreds of thousands, in supporting over 1,000 local elderly and vulnerable patients. When we're not told about these things, we don't believe that there is total transparency of decision making. And when we had many of us tried to attend the clinical commissioning group meeting, only 8 people were allowed in. And so many of us provided questions in advance, and they weren't even read out by the chair. There is a real frustration that we're looking at cuts to NHS right on our doorstep, but it is against the national backdrop of significant cuts. And I do think, of course, they make us all angry, but we are a part of a struggle that is cross-country and is actually cross-generational when it comes to fighting for the NHS. And generations before established Ilkeston Community Hospital, generations before built the NHS, but the next generation is going to ask all of you, all of us, what did you do when they were cutting services at Ilkeston Community Hospital? And I am proud of the campaigning that we have done, whether it's street stalls or leafleting or on social media or on front pages of the newspaper. It is so important. And we are going to keep fighting. And the fight will not just be to protect the services that we have left. It will be to actually reinstate the services that have already been cut. Put back the staff, put back the beds, put back the hospital that we've And I think it's so important, because for our children and our children's children, we want them to have more than just a half-empty building. Thank you.
also all of our question answers who very kindly came along this evening for doing that. What's going to happen now is I'd like you not to run away.
How are we going to get the answers to the questions people are
asking? Steve talked about listening and wanting to answer the questions various extent now. I'm going to suggest that when they've gone in a few moments' time, we make sure we think about what we're going to do next, and that will include getting those questions written down before you go, only about a 10-minute job, and making sure they get to people in the CCG and ECHS. Is that reasonable?
Yeah.
So I'm going to invite our friends to ask for your applause. And just while this is happening,